Okay, so I'd like to thank John and Tony for putting this together again and inviting me. It's a pleasure to be here. So what I'd like to do today, I wasn't totally prepared by Sansi in advance to cover all the UV things that I've been doing with melanoma, and I put something else together. So I'll do some of what she asked, but not all of it. So what I'm going to do today is review and then tell you a little bit where we've gone since, a paper that came out a little while ago on our use of models in UV, microenvironment, immune changes in melanoma. And then I'm going to tell you about some, I wanted you to think about things a little differently than probably the rest of the speakers are going to talk about today. And one of them is a relationship between embryogenesis and metastasis in melanoma. And then I'd like you to think about a little bit benign to malignant conversions and how they could go back potentially the other way. All right, so this is really not as a summary of melanoma, but just to tell you what our interests are. We like to study the front and the back end of melanoma, the initiation, because as was pointed out by Sansa, UV is known to be involved in, say, 80% of melanomas, but the mechanisms are still not that clear. We have a lot of UV mutations, but you know, it's complicated. And we can get a handle on that in a system. And then metastasis, of course, is what kills patients, so that's an easy one-to-one to study. Okay, so models. If you want to make a model for a disease, mouse is a great place to start because of all the genetics, and you can keep 5 in a cage, and it won't completely sink your program, although sometimes it does leak water. You need a bail to take the water out. The problem is mice don't get melanoma. It's exquisitely rare. Probably it has to do with the fact that normally they have hair and they live in the dark, and you know, it's not something that they normally have. However, gratifyingly, if you take some of the mutations that were just discussed and you introduce them into the mouse, you can coax the mouse into getting melanoma, including the BRAF, NRAS, and then there's a variety of ways you could use non-BRAF, non-NRAS models. We like receptor tyrosine kinases a lot, and I think you've heard that they're retaining their interest over time. So the one that we spent most of our time with, and that's worked best for us, is MET. Constitutive activation of MET by expressing hepatocyte growth factor, which is its only real ligand. And so the model involves constitutive activation of MET. And what you see down here is every green dot is the nucleus of a melanocyte. And I'll tell you how we get that in a minute. It's GFP, and it's triggered by a dopa-chrome tautomerase promoter. I'll get back to that in a second. So this is one part of this complicated equation. The other one is UV, as Sansi just told you. And there had been some data for years, that epidemiological data that suggested that burning doses, particularly in children, was a high risk factor. So we reproduced that in the mouse, and when we put these all together, we can develop lesions that look really strikingly like human disease. So here's an example of a human classic pagetoid spreading for radial growth phase, and here's our mouse. And one of the reasons, probably the most important one, that these look so similar is because what you're seeing with these dots here is in the constitutive MET model, the melanocytes survive in the upper regions of the skin and the epidermis, as opposed to almost all other animals, except humans and pigs, I think, where melanocytes are in the hair follicles. Okay, so the story I wanted to review quickly is by Raza Zaidi, who's now moved on to the Fels Institute at Temple. When he came into the lab some time ago, he decided he wanted to find out what UV was doing in terms of melanomagenesis, but he felt that the cell culture systems were inadequate to really get at the questions at hand. So what he did is he made a mouse where dopa-chrome tautomerase drives the expression of reverse TET, RTTA, and when he crossed that with Elaine Fuchs's mouse, which is the TET operon driving GFP, when those are put together, the double transgenic will give you, in the presence and only in the presence of doxycycline, beautiful green nucleated melanocytes, which you can isolate by FACS, follow over time, and just generally do lots of cool things with. So here's an example of the embryo from this mouse. All these dots are melanoblasts except the telencephalon, which is very positive for DCT and then disappears later. And here in adults, you can see confocal image within the bulb, melanocyte nuclei here, and in the bulge, which has the stem cells for melanocytes. And here's a section through showing the same thing at P7. So the first thing that Raza discovered when he UV irradiated these mice was that within a couple of days of radiation, you have what you could call activated melanocytes, which is a proliferation and a mass migration, particularly from the bulge up into the upper regions of the epidermis. And he was very interested in this and how it might relate to melanoma and what caused it. So to try to get an answer to this question, he can isolate these green melanocytes from the skin because they are GFP labeled, so you can just do FACS. And you can see when we started to do some analysis that they're very highly represented by pigmentary genes and very poorly represented by other cell types. And in fact, the purity is well over 95%. And so the experiment that Raza wanted to do right off the bat was to look and see, everybody knows that UV induces stress, and so we'd like to look at that in vivo. And to do that, right after the mice are born, we gave them a melanomagenic dose. So the time period for the treatment, which is an early phase for the mouse, a pup, and the dose is melanomagenic. And then we took the skin and harvested it a day later. And to compare to that, he wanted to know what are the longer-term effects of UV. So he did the same experimental dose and time, but then he waited a week before he isolated the cells. And he wanted to know what the differences was between those two. So this heat map shows you UV, no UV at 2 days and 7 days. So this heat map will really represent changes in development as you move from maybe melanoblast predominantly to melanocytes. But at 2 days of UVB, you can see there's a tremendous stress response, many of the genes that you might expect to be associated with stress. And then by 7 days, as you predict, a lot of those calm down, which you can see here. However, we noticed up here there was a new box of red genes, activated genes that weren't there as part of the stress response. And when we looked at those a bit more carefully, what we found is most of them were actually associated with an interferon presence, and so that they were an interferon response gene. And also within that group, we found a number that had been associated with immunosuppression. So these were all really shocking results to us. So we wanted to know, is interferon really involved? So we did a number of blocking systemic antibodies that suggested it was interferon gamma type 2 and not type 1. And here's an experiment where we use an interferon gamma knockout mouse. And what you're looking at here by the number of melanocytes in the epidermis is that activation that I told you about. You can see that if you use an animal that's knocked out with interferon gamma, I'm sorry, this is a heterozygote, here's a knockout, that whole activation disappears. So it's entirely dependent on this interferon presence and the response that you see. In terms of where it comes from, we looked exhaustively at all kinds of different cells, actually hoped they'd be something else, but it turns out when we finished all the different labeling, it turns out that the only cells in the neonates, the only ones that came in were GR1 minus, but CD11B plus and F480 positive. So they were a type of macrophage. I can tell you right now they weren't M1 and they weren't M2, they were something else. We think that there's a wide variety of macrophages, and the ones that come in here probably are a little bit different than some of the adult ones. So the experiment that we wanted to do is find out what these macrophages had to do with melanoma, if anything. And so the way we tested this, Raza isolated these cells from our mouse after UV radiation, and then took a melanoma cell line that we had isolated from an HGF UV mouse. This is the inducible MET, the constitutive MET model. And so he admixed these together in a 5-to-1 ratio of melanoma cells to macrophages, and to find out if they would change the way the tumor grows. And the nice thing is you could also do plus or minus blocking antibodies to interferon gamma to show what the role is there. And so what he found is, here's our melanoma cells. This is the tumor volume. They're not really very aggressive. and here's a control antibody. But if you put the macrophages in, they grow much more aggressively, and that is reversed if you block the interferon gamma signaling pathway with systemic antibodies. And it's not due to increase in proliferation, it's due to survival. If you look at tunnel assay, you can see that there's a lot of typical amount of tunnel apoptosis that you can see in tumors, but if you put the macrophages in, it basically disappears. And does it have relevance to human disease? Here's some tissue microarrays. We looked at 27. We found that 70% of the human melanomas were very rich in macrophages based on CD68 positivity, and all of those were associated with an interferon gamma signal. As you can see here, here's interferon gamma, here's CD68, and here's the composite, the merge. And in terms of relevance, I'll just point out there's very few interferon gamma studies out there for melanoma. They were always alpha. And Frank Meiskens was asked to do a gamma study years ago, and he told me he really didn't want to do it, but he was sort of forced to do it. And it turns out that they had to stop the trial early because the patients that were receiving gamma were doing worse than the controls. Okay, so this just summarizes what I've told you and some of the things I didn't. When you get a burning dose of UV radiation, there's a dramatic response. So UV could, of course, be causing DNA damage and mutations, but in addition, you're getting this immune response, which we think might be associated with melanoma. CCR ligands are secreted after the burning dose. They find these macrophages that are CCR2 positive and bring them to the skin. We don't know where they are. We don't know if they're in the bone marrow or circulating. We don't know. But they come in and they're activated. This macrophage releases interferon gamma. The melanocyte has receptors, and then the inflammatory loop here is stimulated by CCL8 production by the melanocyte. So this inflammation is fueled and then persists at least for a couple more weeks, as long as we've looked at it. In addition to this fueling, the melanocytes start to express a number of factors, as I told you, that seem to be associated with immunosuppression. So these are sort of non-classic MHCs, complements, and things like that. So we propose, sort of in this, the nature of this meeting, that these immunoevasive mechanisms that we see in this remodeling, when you get burning, the melanocytes are trying to survive, right? Keratinocytes are born to die, melanocytes are supposed to live, and some of the mechanisms that melanocytes use to live, as we see in this remodeling case, we think are recapitulated in melanomas, which make them more aggressive and therapeutically resistant. So one of the themes that I'm going to come back to is hard wiring. Cancers don't occur cells don't become cancerous because they find other ways to do things. What they do is they use stuff that's built into the cell itself. That's why there aren't a lot of drugs that work on all cancers. Every cell is different, and so you have to know about what's hardwired into the cell you're interested in. This is one of the mechanisms for survival that's hardwired into the melanocytes, and I'll come back to this. So the two things to think about are macrophage is a really good marker, when we think they are, and exactly what kind of a macrophage might be important as well. And a bit more controversial, is interferon gamma receptor a preventive or a therapeutic target, much unlike interferon alpha. And I just want to say that in summarizing, not just interferon gamma, but a number of different immune parameters, what happens in cells depends on sort of who's in charge. If the immune system takes control, then they can keep at bay the type of tumor cell. But if the tumor cell ends up controlling the microenvironment, it can also turn the tables, and interferon gamma is one of those factors that can go either way. And we think it depends on the tumor specificity, what kind of cells, the microenvironment, what else is there, and signal intensity. We've actually found that if we put gamma in at some levels, at high levels, it'll kill cells, but if you put it at a lower level, it'll actually stimulate the proliferation of melanoma cells. Two new studies that have come out I just wanted to tell you about that sort of support this idea of interferon gamma as a bad guy. It was found that interferon gamma inhibits the immune-enhancing CXCL9 MIG expression in melanoma, and I think Suzanne Topalian will be here tomorrow to tell you about her studies In a recent paper, she showed that interferon gamma induces immune inhibitory PD-L1 expression in melanoma, and we've seen CTLA-4 as well. And so this is sort of the Janus situation for interferon gamma, much like TGF-beta and other cytokines. All right, I'd like to tell you a couple of stories that are unpublished. I'm going to go through these pretty quickly, but I think they're interesting. So one of them has to do with the hypothesis that metastatic melanomas exploit mechanisms employed by melanoblasts during embryogenesis. This gets back to the idea of hard wiring. Is there something about the development of the melanocyte that might make it more metastatic? So this is not a new idea. There aren't any new ideas. I hate to tell you this, but if you have an idea, you can find it in the literature. You just keep going back. So if you go back 150 years, you found out that Rudolf Virchow, who has a lot of names on books if you see him in the library, neoplasms arise in accordance with the same law which regulates embryonic development. Okay, so we believed him, and we went on and tested the simple idea that embryonic melanocytes, that is, melanoblasts that commit to the melanocytic lineage as they leave the neural crest, go into the staging area, might more resemble metastatic melanoma and be very different from melanocytes, which have more of a homeostatic function. And the idea would be that there are some genes that are highly expressed in the embryo and in metastatic melanoma, but poorly expressed in melanocytes, and then the opposite would be true, low, high, and low. All right? And the thing about this is we can do this study now. Rudolph couldn't. We can do that now because we actually have the tools. We have the embryos to isolate these cells, the adults to isolate these cells, and then we have mice where we can isolate these lesions, of course, as well as human lesions. So this is just a picture of how these develop. Here's the GFP embryos developing over time. This just gives you some idea of how the melanocytes move during development and then set up shop in the skin. And the idea that these two are similar is really not far-fetched because melanoblasts have to undergo sort of an EMT event. They have to migrate, invade, and then they have to colonize at a different distant site. And that's exactly what metastatic cells do. So I think it's reasonable that cells that do this might resemble metastatic cells. And the reason we can do this, again, is we can isolate the GFP-positive melanoblasts and then let them go through an RNA-seq analysis, which we did with Paul Meltzer and Sean Davis at the NIH. So here's a heat map showing the 1,000 most changed genes in development, and then over sort of P7, which was about the time melanocytes are becoming very dominant in the skin as opposed to blasts. Remember, this is this is our original scheme. The genes that we're interested in fall in two categories. One is those that are very low in embryogenesis, but then jazz up a lot, like later and moving into the adult stage, okay? And then the other ones start out high, but then get squelched. And we decided to start in this group, which we call meta-fetal genes for metastasis and related to fetal development, because they're a little easier to study. They're sort of dominant, and you can knock them down and see if they have changes in the phenotype. So here's an example. This was a study that was started by Teresa Guo in the lab and picked up by Praveen Mishra, who's a graduate student. And what he did is an extensive analysis of expression and validation. He did a lot of meta-analysis of clinical data that's out there, Oncomine, other things, and importantly, what genes were associated with survival in melanoma patients. And then finally, functional validation, which included like soft agar and metastasis assays. So we knew we were in pretty good shape early on because in our first group of 180, we had a lot of interesting genes that you might predict. We had TWIS1 and 2, which have been shown to be associated with EMT. Osteopontin's been involved in melanoma for years. MMP2 and 9, of course, for proteases that help invasion. And tenascin C was already discussed today. So this was filtered down to about 16 genes, which are sort of a signature for this study. And we're just sort of validating these and getting them finalized now. They're a little bit too early to throw out there because we want to make sure they're right. But this gives you just some idea. If you take a human cell lines or mouse cell lines, and then do controls. These are lung metastases that you might see with A375, for example. And if you knock them down, then this is what you'll see with some of these genes. And here's an example of how we validate that they have something to do with humans. If you look at survival data, you can find that high and low expression, there's a significant difference in survival. So these genes are sort of not what you'd expect. They're genes that are associated with proteins moving from membrane to membrane, or protease turnover of these proteins, some neural proteins. So very interesting proteins, not the kind of ones that you've been hearing about. Okay, another quick, hopefully not too quick, but a little bit quick, two related stories that are run by Prasoon Mishra in the lab. His ideas really were associated with benign to malignant conversion, and especially could you go backward. So this is the idea that was popularized by Leo Sachs back in the 70s of differentiation therapy. And again, this has not been something that's been popular lately, but I think it's starting to get back. Thomas Tuting had a very beautiful paper just a little while ago in Nature showing how important differentiation is in these cells, and I'm sure we'll talk about that tomorrow. So I have to explain the system, and this is the most complicated slide. I'm just going to go through it a little bit more slowly. So we used, the model here was a cell-based system, and the nice thing about genetically engineered mice is you can take the cells from the mice and use them, and so you can make them anything you want and then isolate them from the animals. So we did this in collaboration with Dot Bennett, and the two types of melanocytes we isolated were those that were deficient in both INK4A and ARF, so the entire CDKN2A locus, or just P16, okay? And what's interesting is about this is when you infect them with activated RAS, one of them will do almost nothing. They look like normal melanocytes. The other ones transform dramatically in every characteristic we can find, including loss of pigmentation. And this is a very high-tech Eppendorf spin of melanocytes to show you the pigmentation and lack. But if you do something else, like a microarray, you can see this change in pigmentary genes. If you put the P16 only cells into a mouse, they pretty much just sit there here over 3 weeks. And if you put these in, they rapidly form tumors, okay? So our question then is, well, you know, what about these? Can these become malignant, and what's involved in that? So we put these cells into the mouse, and we let them go beyond 17 days. If you let them go 2.5, 3, 4, 5 months, what happens is tumors do come out, but they look a little different. We call these zebra tumors. They have that pigment in there still, but then a much larger tumor comes out that's not pigmented. And we know these come from the same cell. We've isolated clones, and we've done this experiment. We can produce it from clonal cells. If you look at these, they're very interesting. This is a DCT stain, and this is the border between these two. There's a section that's amelanonic and a section that's pigmentary. And in this particular one, what we found is this loss of pigment was associated with a loss of ARF. So this tumor exactly recapitulated what we did genetically up here, but in vivo. And what's interesting is you can let these cells go in culture for months, and you can pass them over and over, and they will not lose pigment. But if you put them into the mouse, then they will. Now, they don't all lose ARF. Some of them have this mechanism, some of them have others. And again, Thomas will talk about some other mechanisms tomorrow. And here, if we do a capture of this tissue, you can see it basically reproduces the in vitro system. All right, so that's the model system. I'm going to briefly tell you what Prasoon's interested in is sort of a genomic comparative analysis. So what he did is he took these two cells that we had, and he looked at mRNAs and microRNAs, match samples, and he also took the tissue that we could capture. So now we're looking at a cell-based system and a tissue-based system, did the same thing, looked at mRNAs and microRNAs, took the things that were in common between those, all right, and then he wanted to find out in the mouse what would the particular sets of mRNA, microRNA up and down, you know, to find out what sets might be more interesting. And then to get the further prioritization, he went into human cells, did the same kind of analysis, did the same kind of inverse relationship between microRNAs and mRNAs, and then integrated the whole thing. And at the top of that list, he found MCL1. So this is the myeloid cell leukemia sequence 1, or MCL1, and the paired microRNA was actually miR32, which hadn't been studied very much previously. So he established this relationship that miR32 regulated MCL1. And here you can see functionally these are interesting. If you express miR32, you can see it dramatically changes soft agar colony growth or tumor development. And if you knock down MCL1, the same phenotype happens. You get reduced soft agar and reduced tumors. So we think that these two, this pair, could be important. And if you look at biologic data in humans, you can see that in nevi, for example, MCL1 is quite low, whereas in malignant melanoma, it's quite high. So here's what we think is just basically going on. MCL1 has been implicated in many things, but I think most importantly, it's involved in blocking apoptosis. But when we looked in cells, the kind of cells that I showed you before that we had studied for the pigmentation, what you can see is that MCL1, if you express it in these immortalized melanocytes, it doesn't have much effect. In fact, even BRAF doesn't have much effect, but if you put them together, they actually make those cells much more malignant in terms of soft agar growth. Same thing with CRAF. If you put CRAF together with MCL1, much higher, and PI3 kinase, much higher. So you already know the story about BRAF. Vemurafenib works very well in more than 70% of the cases, but then they all recur, so new combinations are obviously needed. So what we think is, based on this perspectives in melanoma, we would posit that MCL1 represents a promising secondary target to use in combination with some of the other more popular ones. All right, and then finally, one quick story on redifferentiation that Prasoon was interested in. Can you go back the other way? Okay, we have a little bit of understanding of what it takes to go from benign to malignant. Can you take cells back the other way? Is that a reasonable therapeutic approach? So here he used the cell lines that we've already characterized. Here's the highly malignant one, and the question is, can we make it go the other way? This is a drug screen he's doing, okay, not a genetic screen, a drug screen. He's used the low-pack library, and if you screen for pigmentation, what you find is a few outliers of drugs that make these cells more pigmented. And if you look at, that was a mouse assay, if you take those drugs, and we had about 8 of them that we liked, and you can see that if you put them onto human melanoma cells, indeed, they make them more pigmented. And interestingly, if you do a cytotoxicity assay, they're not very cytotoxic. And we wouldn't want them to be or expect them to be. What we're looking for here is a drug that's not toxic, that is going to make cells more differentiated. It's not hard to kill cells. Formalin does it, Clorox does it. What we were hoping is that we'd find something that had a better therapeutic window that might be even more preventive in the long run. Okay, and here you can see what the cells look like. These are these malignant cells. When you put the drug on, you can see they flatten out and they look much less angry. And finally, these are drug dose studies looking at invasion and soft agar colonization. You can see that in 3 different drugs, there's a dose-dependent diminution in invasion and soft agar. So it's not just the pigment, it's these drugs are changing the program of the cells. So does this give us any hope potentially for this redifferentiation therapy? So Prasoon is pursuing this to see if we can do that. Okay, and then I just want to give you the take-home lessons here, sort of bring back this final point. We found that it's very important to understand the relationships between embryonic cells and melanocytes, and then of course melanocytes and metastatic melanoma, the relationship directly, and then the relationship in particular between blasts and metastatic disease. And Weinberg had talked about this in human cells a couple of years ago and postulated that melanomas were very metastatic because of the nature of that cell type. And so we think that a lot of the programs that you can exploit for melanoma are hardwired into the melanoma, or into the melanocyte, I should say, and that the trick is to find out what those hardwired pathways are and exploit them the other way. And the reason we can do these things now is because we have the tools to do them. And previously, they just weren't available. So I'd just like to thank the people involved. I told you about Teresa Guo and Praveen Mishra and the melanoblast metastasis study, Prasoon's work on the redifferentiation, I told you about Roz's work, which is published. I'd like to thank Francis Noonan and Eddie Fabo. They're GW, amazing photophysicists, photobiologists, without whom I couldn't have done any of the UV stuff that I did. Giorgio Trinchieri and Howard Young for helping with the inflammation. Paul Meltzer for the help on the genomic analysis. And I talked to you about Dot Bennett and her cells. And I'd also like to thank a lot of the people who have helped us with reagents throughout the year. And Thomas also for the giving us his data, and so we can compare it with ours early on. Okay, that's it. Take some questions if we have time.